We are going to crank through 3 pieces of literature today. We're going to start with the Simpsons Paradox. We are going to move from that into an examination of the concept of case fatality rate. And then we have a short paper that talks about data collection during the COVID-19 pandemic in general and some challenges to doing that through an interesting case of attempting to discover the importance of weather on COVID transmission and infectivity.
And this one's more of a thought experiment paper. As far as I can tell, they published it in 2020 and it never got peer reviewed, but it has been published by the University of Oxford in a manual on basically the issues with statistics.
Yes, they didn't end up having anything meaningful to say about weather, which is probably why they didn't end up putting it through. But they did come up with some interesting advisories. This was, it was quite early, right, in the pandemic, this paper. And so, you know, it will play into the whole discussion. As we were talking about before, the really, really important thing that we're going to look at here today is not necessarily the statistics themselves that were done, but how the data sets were chosen and how the lines were drawn. In other words, which groups to compare and what to make of them, which drove a lot of the downstream policy and created the world that we've lived through for the last couple of years. So, Simpsons Paradox.
Simpsons Paradox. So, Simpsons Paradox is basically the idea that it is possible to have a group of samples and see that there's some kind of trend in the samples and to end up with completely the incorrect interpretation of what that trend actually is. So the original paper was published in 1951. It was a pretty mathematical treatise. I looked this up, and so it's basically laying out the underlying principles for why this sort of mistake can occur. And what it really boils down to is the fact that when you mistakenly treat groups as being significant in your analysis when you treat them as being insignificant in your analysis, you can end up with surprisingly inverted conclusions. So the first example here is this idea of admissions into Berkeley. So the school admitted 44% of male applicants, but only 35% of their female applicants, which on its surface looks like a pretty damning situation of gender bias. So this bottom chart is the kind of distribution that you would expect if what is being said is true, that you are admitting fewer women than you are admitting men for the same number of slots. But when you look at the actual statistical distribution, what you find is that the subgroups have their own regression. And that is going to often be in the opposite direction of what the whole group is looking like. Like, it's a pretty straightforward...
So in that case, it was like the women were applying to more, more selective departments.
Yes,
is
exactly.
What it came down to. So it was in favor when they did the analysis of a bias towards women overall, I believe.
And
in those departments.
And this is, I think, the most important sentence in this entire piece, which is the fact that we can scrutinize and regroup and resample our data as much as we are able to. But if multiple different conclusions can be drawn from all the different categorizations, then choosing a grouping to draw our conclusions from in order to gain insight and develop strategies is a nuanced and difficult problem. If we have this example of Berkeley admissions, and then you can very quickly, shuffle things around and figure out that there's actually other groups that you should be looking at, it's fairly straightforward because UC Berkeley is a bin, and you have yearly numbers, and you keep statistics, and you have a very neat boundary condition for the analysis that you want to do. But when you turn to something like COVID, where you have an absolutely open-ended realm of exploration, or if you turn to something like heart disease, any kind of public health issue, you start to really quickly enter into this land where the decisions that you're making about statistics are going to change fundamentally based off of the groups that you use. And so this is why there has been a push recently in biology and in the science, in experimental science in general, to pre-register your studies. Because what happens is that if you have a set of data and the set of data can be analyzed with any number of parameters placed upon it, it means that you can do this thing that's called p-hacking, which is that you reanalyze your data that you have collected because you have a huge amount of it in a way that is different from your initial approach. And that reanalysis allows you to find something meaningful in a sea of noise. And that basically is a manifestation of Simpsons Paradox, because if you can reanalyze data that says one thing and have it say something else, you can pull any result that you want out of that information. And so pre-registration is the solution, because you sit down and you say, I'm going to look at this group versus this group, and this is what I expect to see. And that way, if you run the experiment and you look at that group and you don't see it, then you have to wrestle with that, as opposed to being like, oh, well, we saw something else, and so we'll write about that. This is elaborated more fully here, where it gives an example of, sinful strawberry versus passionate peach, and you have your sample size and the number of people who like the flavor. And so you can see that 80% of the sample enjoyed the strawberry flavor, 75% of the sample preferred the peach flavor. And that's your 30,000 foot view. But when you start to break down how these actually ended up working out, if you break it down to a little bit more information, like not just the number of people who liked it, but the number of men versus the number of women who liked it, and the number of men and the number of women in your sample, you start to see that there is a breakdown because of your sampling size and the respondents within that sampling size. And, when you look at it like this, when you start to see that what's really driving it is the difference in sample size, it becomes not that strange of a paradox. Because you would expect that when you have one group is the larger group, that would tilt your analysis in that direction. And that's kind of what we see here, right? So we see that.
And if you know you have two groups, then you're fine. But sometimes you don't know you have two groups.
Mm-hmm.
And that's where this really goes off the rails, when you hear these big overarching statistics. Like you still see these all the time, like crazy headlines that come out that are like, exercise is bad for you or something. And that they haven't actually separated out based on something simple like age or something like that, right? I don't know. This is a very common situation where the groups haven't been teased out. If you're looking, obviously, if you know that there's men and women that need to be looked at, then you're good to go. But that's what doesn't actually pop out usually.
Mm-hmm.
In the the one we're going to be talking about today is obviously age. Age pops out as a huge one in some of these analyses with COVID, where oftentimes there's wildly different populations in terms of responding to different treatments and in terms of risk, and they're prescribed essentially the same course of action lumped together, and you end up with pretty extreme policy decisions as a result of that.
And what this comes down to is probability theory, right? So you have always the chance that there is a lurking variable. And when you are making your statistical conclusions, you have to be sure that your probability assessment is looking at the correct variables that describe the situation, right? So when you look at the probability that somebody likes strawberry, so this is the notation, the probability of liking strawberry is equal to the probability that that you're male and you like strawberry times the probability that you're male plus the probability that you liked the strawberry and you're a woman times the probability that you are a woman in general. And so basically this construction is saying that you have to scale the probability of liking something by the probability that you carry some kind of identity. And this can be extrapolated outwards, where you say that, if you're looking inside of a study for the way that nicotine affects COVID, it's like the probability that you smoke and you're a man has to be scaled by the number of men in your sample size. And ideally, the number of men in your sample size would be the same as the number of women, because you're trying to get a representative sample. But that's not always the case. And so if you mistakenly throw away variables that matter, or you include variables that don't matter, you're going to start scaling these parameters incorrectly. And it's very easy to be led astray in probability, because at least at some level, your selection has to do with what you think is relevant. And I think that this is a really good visual explanation of this, right? So the probability of being male and the probability of being female is, in the case of this strawberry flavor, causes the total probability to be significantly shifted towards the male opinion. And there's still this hidden male bias in the passionate peach sample, but it's not quite as strong, and thus a greater proportion of the female opinion is being taken into account. And so there's a lower marginal probability for the general population to prefer this flavor, despite each sex being more likely to prefer it when separated within the sample. And so this is kind of the spread of women versus men who like the flavor. And then as you analyze them together in a single bunch, you have the probabilities cross over into other directions, because you skew them in favor of who is more represented in the population sample. And this is kind of, which data do we look at? And this is a perennial problem in all scientific endeavors. How do we know that we have constructed an accurate sample? Because this is, I pulled these various little animations of sampling error. That this is a professor of economics, and he basically shows that if you have this true sample of individuals in the population or cells or whatever else, depending on how you sample, you can get a completely different estimate of the average, right? Because when you go out into the world, you're never going to sample each and every single individual. You collect some sample and you're like, well, this is representative. And you make some controls, you tell yourself that it's representative, but when you look at it in context of what is missing, you can begin to see that there's actually quite an enormous amount of variation, where there's actually no trend in the background data, in the true data. But because you've sampled incorrectly, you can get any number of trends from the data that you're looking at. The same thing if you look at how you're changing dependent versus independent variables. So depending on how you graph your data, it's possible to scale data. Oftentimes people will multiply their data by some factor. And if you're scaling just one of your variables, that won't change your if you're scaling your y variable, it's going to change both the slope and it's going to change the intercept. So it's going to change fundamentally the characteristics of the regression that you have created, and it is going to give you a misapprehension of what's happening at the tails of your distribution. But that's not the case for both variables. If you're scaling your x variable, you're not going to mess with your intercept, and you're just going to change the slope. And so as you manipulate your data, as you change the way that you've scaled things because you need to multiply it by some factor, it's possible to introduce error that you're not even aware of because you don't realize that doing a generic multiplication across the board is going to significantly change the calculated regression.
Can you think of an example why you'd scale something in these analyses we're talking about today?
This is a more general case. I think that I was thinking more about like the kind of analysis that I would do in grad school, where it's like, my data on the y-axis was so much smaller than the x-axis that you'd like multiply it to bring it up to the same magnitude in order to be able to present it on like a similar scale. Let's see. This is also again about sample selection, which is that if you have a population and you are systematically excluding some portion of your population, what's going to happen is that your representation of the trends in the population is going to change significantly. But that doesn't hold. What's that? There's one last one that I want to show before we go, which is this demonstration of Simpsons Paradox, which is that and he uses this x and y because it's your dependent versus your independent variable, and he's basically saying that as you change the orientation, as you change the alignment of the groups in terms of their spread and their variance, that you start to see a reversal of the trend. And that is not always easy to catch if you think that you're treating your data correctly, when in reality you are introducing statistical errors. I think that's kind of all that I had to say on
wonder
that.
if we shouldn't just like come back to this after we talked about the COVID situation itself.
Sure.
Because this is very abstract. Like I'm not sure that people even understand dependent, independent variable at this
Sure.
point.
Okay.
Like I'm having a hard time translating this to immediately to the discussion today.
All right.
I think that's maybe like more
Which one do you want to do first then?
the big one, yeah. Not the weather paper.
This one. Okay. All right.
Because they bring up a lot of these issues, and we can jump back over to the Simpsons Paradox and point out how they happened. Because they've happened in real life in this papers.
All right. You want to lead us through it? You got to do it on this computer though.
I have different notes than you. Actually, I want to start with this figure. I don't know what to say about the beginning here. Do you want to say anything about this? This is the main figure that I grok. All right, so I want to actually start with figure 4, where they've gone through and they've looked at the Italian data. And what they've found here is they're actually comparing the overall mortality from previous years to the mortality during the pandemic. And what's kind of interesting is they do actually find a big bump in overall mortality across this 5-week span here. What they also don't find is that spike does not appear to have happened in other regions of Italy.
Well, it does happen. It's just not as big.
It's within the noise levels. Isn't that what you decided?
For a different part of the year, yeah.
Like for this one?
Yeah, it's a different part of the year that's that noisy.
Mm-hmm. So, like for instance, in 2017, maybe, or 2018, it looks like there was a bigger spike in the earlier part of the year. So, what's even maybe more interesting is, of course, for the other age groups here, 15 to 64 and 0 to 14, there's really no appreciable bump. There's a small bump over here, but if the data was being reported this way, you obviously have a huge and brief concern for this population, which does not fit into the overall case fatality rate. Let's go back and see if we can pull out where they start picking on the case fatality rate. Maybe it's later.
So figure 1 here is basically attempting to show that you have a couple of different ways of looking at the same piece of information. You can look at the number of confirmed cases versus the number of tested cases, or you can look at the number of deaths versus the number of confirmed cases. And what you are looking for is you are looking for a measurement that is not going to be affected by the number of times you check to see if somebody has COVID. Because if you look at the number of confirmed cases divided by the number of tested cases, what you see is that you reach a peak in the maybe the second week of March. And then what happens is that as you continue to test and you increase the number of tests, you are actually starting to see a decrease in the number of confirmed cases relative to the number of tests. If you are looking at a population and you are seeing an epidemic that is exploding, you would not expect to see a decrease in confirmed cases relative to the number of cases that you have tested. What this is telling you is that as you roll out more and more tests, you are actually seeing a decrease in the number of cases. And so this measurement is unstable and is inherently biased by the application of tests. On the other hand, if you're looking at deaths versus confirmed cases, what you see is that at first you have way more confirmed cases than deaths. And then as the first month of the pandemic progresses, you end up hitting this saturation point. And the saturation point is not affected by testing because you're looking for hospital confirmed cases. You're looking for the same set of people at each time point, which is people that are sick enough to have presented in hospital. And so this measurement, when it stabilizes, is actually giving you a more informative measure of what's happening in the pandemic, because you've basically come to a point where you have stabilized the situation and you are no longer seeing an increase of death relative to confirmed cases. And their point with this is to basically just say that because your testing variable is shifting, that you cannot trust it to give you an accurate picture of what is happening, as opposed to just looking at the number of people who die versus the number of people who have been shown to have COVID by hospital confirmation, rather than just some kind of test that has a false negative, false positive, whatever.
Yeah. So the positives are the definition of what an infection is too gets a little shaky here. I'm not sure if it's this paper or the next paper, but they're already quite early on acknowledging that there's a large percentage of asymptomatic people. And
what you can see in this figure 2 is that this is kind of another visualization of the same example, where they're saying that as you increase your testing, you are not seeing the number of cases, the number of confirmed cases rising with the tests. And so what that's suggesting is that your testing is maybe catching the same people over and over again who have already tested positive for COVID. You are seeing cases that are not going to develop into a confirmed case, because there's no guarantee that what you're testing for is actually going to lead to disease, because you can either have old circulating virus, or you can be asymptomatic, or any number of other things. And for the same data,
they are those two curves are very tightly correlated, though. Like the peaks and troughs are very tightly correlated, which is interesting too. I think they're trying to highlight that in the second part.
Mm-hmm.
So the more that you look, the more that you will find cases.
What's interesting is that the next part of this paper, they're basically like, go look at all of these other cities. And what you find when you start to look through the appendix, where they have basically alphabetically organized cities, is that they're like, I don't think that the data collection is good enough for us to be able to draw the kinds of conclusions that we're making about this, number one. And number two, I think that the pandemic is already starting to pass, right? This paper was written relatively early in 2020. And what they're basically showing here is they're like, look, after March 15th, we're starting to see a decrease in tests and in cases, which means that whatever epidemic peak happened at the very early stages where the vast majority of people who are susceptible have already passed. And now we're starting to see the tests demonstrate that the epidemic is no longer climbing.
So, and they actually demonstrate the same thing on on this cruise ship, which is like their little laboratory.
Yeah, so each one of these is graphed relative to the Princess cruise ship. So the Princess cruise ship was basically a cruise liner that had, I want to say, 270 people on it. Something, is that true? That seems
I don't
too
know. There's
low.
like 3,000 people on the ship. I'm
There we
not
go.
sure how many died or how many got sick.
And so,
But essentially, the infection. This is the infection. The cases, I think.
the confirmed
The
cases.
confirmed cases were standard, right? Whoever was going to get it got it right up front, and it stayed that way. And that's interesting because it's not an explosive event where everybody's going to be infected. Obviously, the data point ends at the data set ends at some point because everybody got off the ship. But if we're looking at something that's like wild, like Ebola or something that's wildly infectious, everybody's going to get that eventually. The thing's going to just skyrocket straight up, basically. But that's not what happened here. Some population was affected by it, and then it leveled off. And that's what's happened in every single place. It's actually decreased when you account for the testing amounts in most of these cities, all these cities.
And I mean, and this is kind of where it starts to get tricky because you start to look at the data from city to city. And what you start seeing is that a lot of the data is really difficult to parse. So these statistics that they have here, which are the confirmed test versus the fraction of cumulative tests, they're very not, they're very big blocks of time because if you look through the text, what they've done is they've basically taken the averages over the course of a week and then they've graphed them for the entire week as being representative in order to smooth out the insane ups and downs. And if you look at the if you look at the data that they do include a more refined assessment of, what you see is that even there you're getting these really massive swings in confirmed tests and or just in testing number. And so they're basically saying, they're like, look, I think that there's a fundamental issue with the way that we're collecting the data for this. Because if you were seeing a really accurate and robust public health collection of this data, you wouldn't be seeing these huge swings. Like Emilia-Romagna has this huge swing right before April 1st. Then the data from, I can't pronounce these Italian names. So the data in this town, up like even for the first month, is kind of scattered. Then you have the same thing that's happening in a bunch of the other cities. And so they're basically saying that, look, if you analyze this case by case, you start to see that there's inconsistencies in the way that the data is being harvested and put into the public health categories. And even if you're not necessarily, but if you even ignore that and you throw away the towns where this data is just an absolute mess, what you're still fundamentally seeing is that in almost every town where you test, what you see is that as we begin to test wildly through the population, the case numbers are not increasing. And that's indicative to us that there was an epidemic of some kind, that the epidemic has at this point begun to slow down.
That's why I started with figure 4 too, because ultimately it seems like what these people are advising is that, hey, the best marker for what's going on and how dangerous this is how many people are dying compared to last year at this time. And not only because that's the most important factor, just because people are dying, but also because it tells you the beginning and end of the phenomena that you're trying to study better than anything else. So a lot of these are not particularly remarkable, but in a couple of places, if you had compared those at the time they were happening, you could have easily contained those. Here we go. There's a couple of towns where you could have probably contained the problem without locking the entire country down, because these were the countries where there was actually excess mortality. There might be a good reason for that too, that it has nothing to do with this being a particularly nasty variant or something in these towns. These could have been towns with particularly susceptible populations, for instance. I don't know the details.
I remember reading about Lombardy as being a place that had a particularly large quantity of sick people. or older people who are susceptible to getting sick.
Now you see there's a little bump in the young people too, but they could have been hospital workers taking care of the old people. Like there may be more to this than meets the eye, but certainly, there's quite a bit of group by location and group by population breakdown that, if this stuff is factored into future pandemics, we might have a way to act very quickly and effectively to minimize the damage without causing more collateral damage, right? Because the best way to defeat an enemy is not always just to throw a nuclear bomb at them. Actually, I would say that's almost never a good idea. The best way is to very quickly neutralize them and stop the enemy from being a threat and without hurting anybody else around you. And I think that this pandemic will go down in history as having caused a lot of collateral damage that was due to just some naivete about how to properly look at the data and respond to it in a very specific surgical way.
Well, because if you look at something like the data from Emilia-Romagna versus the town of versus, let's say, Lazio, because that's one that I can pronounce, you are in a position where if you are at week 10 of the year and you start to see your total number of deaths start to skyrocket above the baseline, you are in a very unpleasant situation where you have to make this decision about what it is that you're going to do, not just in your town, but what are you going to tell the people in the other towns? And the people in the other towns have to make this decision where they don't know what's going to happen in the future. They don't actually know anything about their people necessarily. And so they have to they have to look at what's happening in your place and they have to say, well, that's probably going to come here as well. And that's where the immediate response definitely requires you to make this kind of prediction about the future, but you have to be able to come back around to it and you have to be able to look at your statistics and say that, hey, this wasn't universal. And so when you look at the way that these distributions work, there doesn't seem to be an easy rule of thumb that you can tease out of this, right? So if you were to look at the number of deaths per week, this Emilia-Romagna has about, through the first 10 weeks of the year, about 1,000 deaths per week. And then this town, Friuli Venezia Giulia, has about 300. And so maybe you can make this conclusion where you're like, oh, well, it's the places that have the higher number of deaths per week that are going to be the ones that are going to get hit hardest in whatever next epidemic comes, because clearly this comparison of these two towns tells you that. But then if you look at Lazio has a similar pattern of deaths where it has about 1,000 deaths per week for the first 10 weeks of the year, and it doesn't have the same sort of pattern as Emilia-Romagna does, which is to say that simply looking at patterns of deaths is also an insufficient analysis of what's actually happening, because it's not actually telling you why it is that those people in those towns are getting sicker and dying more. And so you have to find ways to break this data out into even more groups in order to be able to say that, okay, well, what is the age distribution in this town? How many people smoke? How many people have multiple comorbidities? Is there some thread that we can pull on in order to advise people more carefully than to simply say that the risk is universal? Because quite clearly, the risk is not universal. Remember, these lines have to do with ages. And so even though you do see a small peak in mortality for those that are between 15 and 64, the vast mortality is in those that are 65 plus. And so is it possible that the difference between these places has to do with the number of 65 plus people who live in them? It doesn't seem unreasonable for that to be the case, but at the beginning of the pandemic, that was not how the data was being presented. And even to this moment, that's still not the way that the data is being presented. And I think that that's kind of the overarching goal of this paper, is to say that, like, hey, when you really break this out, we start to see things that are not representative in just looking at groups in general.
Yeah, no further comment.
Okay, so let's look at the other paper.
And there's probably really good stories for why those towns are affected differently too. I just
But we don't have
we
that
don't have
data.
them. Yeah.
Like it's literally it is not an undertaking that.
Let me make sure. Let me make sure I don't have any more notes on this.
Do you want to look through it like page by page?
No.
All right. Okay. So this paper was quite interesting. Thought experiment paper, not really a data paper, but I think that it's still very useful. And the conclusion that they draw is a little bit. I mean, it's a conclusion that I feel great familiarity with, which is the fact that there are general limitations that could severely undermine any similar analysis using existing COVID-19 data or similar epidemiological data, which could therefore mislead decision makers on questions of great policy relevance. Like, this is what I wanted to say just before we went into this lecture, which is that statistics is the mechanism by which governments choose what to do. I don't really think that there's a different way for governments to be able to evaluate the efficacy of their interventions, the need for whatever intervention that they're planning on doing. And so you have to have faith in the numbers. And there's not a situation where you have a government and they ask their statisticians to come up with a number and the statisticians are like, we can't. That's their jobs. They can't say that they can't come up with a number. They have to. And it's the job of everybody who's on the outside of that to look into the system and to be able to say, well, hold on a second. Have you made the correct assumptions? Have you been able to analyze your data properly? And is it actually leading us to a real prediction? Or is this just kind of going to fall apart the next time that it rains? Something that
I think they did something really smart here, though, which makes this particularly valuable. They picked on weather as opposed to anything else that was actually substantially important in COVID, which is really cool because they kind of eliminated any sort of bias they have at any particular outcome with COVID. So they're going to basically walk us through an example of how false positives and false negatives could lead you to a conclusion about weather that just might not be true. Might be true, but they feel like there's no statistical power to make that claim based on these underlying biases. And then at the end of the article, they're like, hey, what we just did with weather can apply to all of these other meta studies that have come out that have looked at the same Johns Hopkins data, and that all of our policy decisions are being based on. So instead of picking on the actual policy decision based papers, they've just made up a completely, I don't want to say like defanged example, right? Weather, like people get sick more in the winter, right? Everybody kind of knows that already. And they're like, hey, let's investigate that as an example of whether we can actually even say that is true for sure. And they can't at the end of the day.
Right. So basically, everybody recognizes that maintaining these databases is very useful because if you don't have the database, then you can say nothing. And presumably, our goal is to be able to say something of utility because otherwise, why would we spend all of this money into collecting and maintaining all of this information?
And we this was hurting us last week too because last week was we talking about vaccines last week? Mm. Yeah, we were talking about vaccines last week, and we got some of the best papers, the most cited papers. We brought them to class, and we realized there were serious issues with the strength of conclusions that could be made from a lot of the data that we went through, and a lot of it was based on how those groups were divided up in the first place, not based on the actual analysis of them.
And there's also the size of the groups too. A lot of the times, if you have statistics where you have 100 people in your sample, we know that 100 people is not statistically representative of any group. And so the smaller that your sample size is, the less robust your data is. And so the hope is that you can pull together a lot of different statistics from a lot of different places and basically be able to cobble together some kind of complete picture.
But that's kind of a pipe dream, right? I think the real solution to this, we talked about it last time, is there has to be a standardized way of acquiring data and processing it. There has to be. If all these institutions are actually going to work together in the future to make for pooled data that's relevant, they have to conduct their trials the same way. They have to admit patients the same way. They have to keep their notes the same way. Otherwise, you have this like apples and orange mess where you have a bunch of underpowered studies that you can't combine and get anything meaningful out of them, and you've just blown millions of dollars and accomplished nothing. And your conclusions might be true, but they might not be true, and you have no way of knowing ultimately.
I mean, this is the setup for this paper is kind of amazing, right? So our initial aim was to produce a detailed statistical analysis of the relationship between weather conditions and the spread of COVID-19. And they're like, we took this on because people in the news were talking about how maybe when the summer weather comes, it'll slow the spread of the virus, and so things will slow down. But then we did the analysis, and we came with the conclusion that you literally cannot make any reliable statistical case here. We are terrified by the complete unreliability of the data, and we know that people are still going to be making conclusions, and so we're going to try to walk you through why we think that these conclusions are very, very shaky fundamentally. And man, I think that the wildest thing about this is that you could come up with a paper that comes up with the opposite conclusion.
Oh yeah, quite easily.
Like somebody could look at that database, and if they weren't interested in opening the conversation up about statistics and data collection and epidemiological measurements, they could come up with a paper that tells you exactly what you want to hear about COVID and the weather.
Well, they did actually find a very weak correlation between them.
Right, and so you could play up the weak correlation, and you could make it seem like it's stronger than it is. You can continuously...
You could interpret it, you could come up with reasons why, you could focus on it as already a given.
Mm-hmm.
You could focus on groups that brought out the statistics to be even tighter, like, not because you're malicious, but because that's what you believe. Like, it's wild. I think oftentimes people leap really fast to the idea that mistakes come down to somebody being bad. And it's like, that's not what I'm seeing here at all. I'm not seeing people being bad. I'm seeing people really reinforcing their belief systems about how this should be unfolding in the first place. And a lot of people are very afraid, and it's been a wild ride. So let's go through it a little bit.
Right. So right off the bat, several challenges could undermine any causal statistic analysis of the influence of a potential determinant such as weather on the spread of COVID-19. So any number of confounding variables are likely to pose a significant problem.
Like, not going outside means you won't have as many social interactions because it's raining or snowing.
And fundamentally, there are significant challenges that come from the limitations of the COVID-19 case count data itself. And this is kind of what they were talking about in the previous paper, which is the fact that if you're trying to compare across countries or even across counties or even across cities, the testing capacity of a place like New York City is not the same as the testing capacity of Des Moines, Iowa. These are places that are not going to be able to tell you the same thing about the number of cases that they have in their midst, and that's just a fundamental limitation. And so when you're trying to look at, countries versus their testing capacity, you are running the risk of what the last paper was talking about, which is the fact that as you test, you decrease your positivity rate, and so you are not your number of cases depends on the number of tests available because you have not yet saturated your number of tests that have been administered, right? So insufficient testing capacity has an effect on the number of confirmed cases. In figure 1, panel A, we distinguish between the 3 phases of limited, intermediate, and widespread testing. In phases 1 and 2, there's a risk that the number of confirmed cases depends more on the number of tests available than the actual number of people who have COVID-19, questioning the validity of any analysis that relies too heavily on this data.
That would include case fatality rate.
So basically, what you see here is that in phase 1, you have almost no tests, and so you have almost no confirmed cases. But your actual number of people that's infected in the population is significantly higher, right? If you haven't looked, you can't see anything. And then there's a critical point where you start to administer more and more tests, but you still have this gap between the number of tests that has been administered and the number of tests that have turned into confirmed cases, where it takes you a long time into the saturated end of the testing curve to actually have a one-to-one relationship between the number of people in the population that have COVID versus the number of tests that have been confirmed as cases.
Plus, you're catching up on all these people from before that you missed in the first place.
Well, they're falling out, too.
I just don't understand why these are so separated.
That's
Your
just the number of tests that you've administered, period. That's your testing capacity. Your testing capacity rises infinitely. As long as you keep manufacturing tests, like there's no reason that this number can't go to infinity. However, even if your number of tests goes to infinity, that doesn't actually have a bearing on the true number of cases that are happening in the population. And then on the right, there's the fact that, okay, so you have testing capacity. Let's say you're operating in phase 3, where you have enough tests that have been administered in the population, and these are daily counts, right? So this is number of tests that you can administer daily. And so your confirmed cases accurately reflects your population infected because of your surplus test capacity, which means that you're testing so many people that you're not missing anybody. Then you have a question of test accuracy. We've all heard of false negatives, false positives, and this is a visual representation of the different ways in which these can work. So your actual COVID situation, your actual epidemic, is a measure that excludes all false negatives and it excludes all false positives, right? So there's no false measurements, and it's represented here, where your number of true positive tests is exactly equal to your number of confirmed cases. But that's not the world that we live in, because we are continuously at the mercy of our methods, because our methods are not ideal, and our methods misrepresent reality because they're not ideal. And so when you are taking a measurement, your measurement could include false positives. It could include both false positives and false negatives, or just the false negatives, but no matter what, you're going to get a different estimate of what is actually happening in reality, and you will have no real way of knowing the failure of your test versus the measure of reality unless you have very, very good understanding of how all of your tests are administered and how all of your tests fail. And as somebody that has worked in a lab before, as somebody that has run RT-PCR, as somebody that has done these sorts of experiments before, I can tell you that the rate of false negatives or false positives due to user error must be astronomical, because they're not straightforward tests. You have to go through many, many steps. And there's people that are running these tests are running them in high throughput conditions where it's easy for there to be cross-contamination. And
when you're surveying hundreds of thousands, if not millions of people, it starts to actually add up and matter at some point. I had a really good case recently that was about those DUI machines. And it was something like some guy got pulled over.
Oh, this is on the Wikipedia for.
Okay, let's have me not mess this up then.
Yeah, I'll find it. You go ahead.
But no, I don't want to mess it up if you're gonna.
It's called the base rate fallacy.
Let's just pull up their numbers.
All right. So.
This is great. And we'll tie this back to COVID in just a second.
All right. A group of police officers have breathalyzers displaying false drunkenness in 5% of the cases in which the driver is sober.
False positive, right?
However, the breathalyzers never fail to detect a truly drunk person. 1 in 1,000 drivers is driving drunk. Suppose the police officers then stop a driver at random to administer a breathalyzer test. It indicates that the driver is drunk. We assume you know nothing else about them. How high is the probability that they are really drunk? So people read this and they're like, okay, well, there's a false drunkenness report in 5% of the cases, which means that there's only a 5% chance that he's falsely or that it's a false positive, which means that the actual rate is probably around 95%. But the correct possibility of this is actually closer to 2%. And the answer for this is basically, it's laid out here. So for every 1,000 drivers tested, you have one driver that's drunk. And it's 100% certain that when you measure that driver, there is a 100% chance that this person is actually correctly drunk. That's not going to be a false positive. Definitely accurately drunk. But of that 1,000, you have 999 that are not drunk. And so among those drivers, there's 5% false positive test results. So among your entire sample, there's only really about 50 false positive test results. And so your actual estimate of whether or not this person is really drunk or really not drunk has to do not with the overall sample of the drivers that you're looking at. It has to do with the fact that you have to look at, in the remaining drivers that are not drunk, what is the likelihood that the test will give you a false positive? And that's only 50. And so your probability is that it is 1 out of 50, and that's 2%, as opposed to being 95%, which is the instinctive answer that people give because of the base rate fallacy. Can you tie this back to COVID?
I don't know.
Well, the way that this ties...
I was trying to look up the actual false positive rate. They're not so easy to find.
Right. So the way that this ties back to here is that base rate fallacy is more of an example of cognitive bias, right? Where people are largely enumerate. And so when you give them a word problem, they have a tendency of misapprehending what your sort of your groups are that you're attempting to compare and how to do the comparison. And the way that this relates back to COVID, as far as I can tell, is that it's quite easy to relate. Like, if you make this mistake about what your false positivity rate is, because you have incorrectly estimated it, your base rate is going to be off. Because if you, in the example that we gave with the drunk drivers, the likelihood that your estimate is incorrect is 5%, right? So if you're like, okay, we have a 5% false positive rate. But if your false positive rate is actually 25%, or if your false positive rate is actually less than 1%, then it's really going to significantly change the measurement of how many cases that you actually have. And estimating the percentage of false positive rates versus the percentage of false negative rates is not an insignificant question, because I believe that it's probably unique for each lab. Because these tests are run by individual people, and those individual people have something that in the sciences is called hands. And so when you have hands, you have a certain error rate for your experiments. And I would see this in every lab that I ever worked in, which is the fact that people would do the same experiment and they would get different results. And there would be the person who got the results that were much more in line with what the results were desired would be the person who would from here on out do that experiment. And then if you have a lab where everybody is doing the results and those results are being pooled and then being sent out into the world, it's entirely possible that there's a hidden false positivity, false negativity rate that isn't being calculated because it's just an insurmountably difficult thing to collect. And so you get some average rate where 5% of the tests in the country are false positives. But in reality, that's not an accurate number. It's just a number that we have told ourselves to be able to move on, to be able to make the next calculation, which is how many actual COVID cases do we have? Dr. DeLay is still feverishly searching for false positive rates.
Buried. Really buried.
So, and these two things about the concerns about test accuracy and concern about test saturation are issues with every single COVID-19 confirmed case count and mortality. Because you are relying on people to have correctly collected these estimates. And whenever you rely on people to do their jobs correctly 100% of the time, you're in for a world of hurt. And when you are making enormous conclusions about the future of the world based off of people's statistical sort of machinations and their entries, you have to find ways to control for that so that you know that you're making the right decision. So they basically lay out the fact that they're like, look, the data's sketchy, but we'll go on, we'll look at the weather. So the main problem is that the weather could be influencing the number of tests that are carried out and the segment of the population is tested. You know for a fact that everybody is going to change how they behave when the weather changes. Number one, when the weather changes, you're going to start to see a lot more respiratory illnesses that don't look like COVID, that look like COVID, which aren't COVID. And so people are going to start getting tested for those. And so they have symptoms of respiratory infection, but they're not confirmed cases yet. So even if they model it and they're like, look, when the weather turns bad, you get more COVID cases, you can't tease apart whether you have more COVID cases because people have been sniffly and so they get tested, or if the weather itself is actually making COVID worse. I like this, that they're like, Table 1 provides a non-exhaustive list of elements that could undermine any analysis of the impact of the weather. And then you go over to look at Table 1, and it's very straightforward, right? So you have a weather-sensitive respiratory disease, you have other pathologies that are affected by the weather, and the fact that people are more inclined to seek medical attention due to the weather. So based off of the evidence that they have collected, the weather may actually correlate with the number of tests and who gets tested, but they can't actually find any information as to whether or not there's a larger effect of the weather in terms of test accuracy, where it's like...
I think there's a figure that might work really nice with this.
We're coming to it in just a second, yeah. So let's see. They talk about the weather conditions that have an indirect effect on the spread of COVID-19, which is social interactions or air pollution. And those effects could be heterogeneous across the population, which means that not every single group of people is going to be affected by those in the same way. People who live in Minnesota might not be affected by it being 40 degrees out the same way that somebody in Los Angeles is affected. And you also have the fact that people travel, right? So you're getting people who get COVID in one place and they travel to a different place. And that's not the same thing as being able to say that everybody is always in the same place. So figure 2, panel A, exactly, so it illustrates how we could have obtained a negative correlation even if the temperature had no impact or a positive impact on the spread of COVID-19 in our sample. So we go to figure 2. And so we have a couple of different things here.
And this is, somebody was asking before what we could do about it in the future in some context. And this is the kind of drawings that you should be making when you're designing a study. You really need to think about all the ways that things could go wrong. I really love this illustration. I think this is something that should be coming out. This should be half of your statistical class, is looking at your variables, looking at your effects of your biases on each one of these, the effects of your oversampling, the effects of your undersampling, false positive rates, and how it's going to play out. So,
can you walk us through? You want to walk us through it?
Sure. So, in the first part, so in each case, the actual effect is in green, which is buried in both of these. In A, the bias actually is because the weather has affected the tests. So there's people who are...
So as the weather gets cold, you get more tests, and as the weather gets hot, you get fewer tests. Right?
Says changes in the number of people with respiratory diseases other than COVID.
Yeah, exactly. So the estimates of the...
So people get sick and they come in and they're getting tested.
and they're getting tested, and there's some rate of false positive cases. And so as you test, you increase your perspective on the number of cases in the population, but it's a false increase. And that false increase in terms of expanding your COVID-19 perceived case number is smaller when it's warm outside, because there's fewer people that are getting other respiratory problems when it's warm out.
Right. And then in the second one, we're talking about how human behaviors change as a result of the weather, which is sort of a third variable that's not being accounted for. Yeah. So you go outside more when it's warm, essentially.
But why would that affect, like, why does that change the estimate? Let's see what they have to say in the
They're
text.
saying it's the opposite in this case. This is how it would lead it in the opposite direction.
Right. So basically, like, the circles in blue capture what they say is other underlying factors that are influenced by temperature. So
obviously, that's not like what they didn't compute that this trend is the case. They're just saying that it could have been obscured.
Right. And so because people were getting tested based off of how often they saw people, and you tend to see people more when it's warm outside and you get together and you're barbecuing or you're doing your thing. And so that also creates a situation where the increased temperature changes sociability, and the increase in sociability changes the way that you are encountering the entire testing and tracing paradigm.
I mean, they obviously did see it trend towards A versus B, but they're saying that they can't actually get a grip on the size of that effect, or even if whether it was real, because B might be obscuring the reality of A, or vice versa.
Right. And so they're also saying that there's reasons to be concerned with these temperature dependent effects that have to do with the estimates that vary between samples, because you have, at the beginning of 2020, you have a lot of estimates that are coming out from countries that have wildly different temperature conditions, right? Italy is a temperate Mediterranean climate. I would bet that January, February, you have probably like 15 Celsius average temperature. The average daily temperature in China is lower, it's 10. And so that immediately is giving you a potential weather-related shift in how these countries are reporting. And then on top of that, countries that have implemented a stringent containment period, which is lockdowns like they did in Italy and China, could have massively changed the way that the sensitivity of the spread of the disease is affected by weather, because the fact that you can't actually go out and see anybody, because despite the fact that the weather is affecting this, you can't actually see it. And so what they're trying to say is they're like, look, we're not looking at this in some bubble where every single condition is the same and every group is the same and everything is the same. We're looking at this between different countries that have particular strategies in place. They have specific cultures in place. And when you ask a question as specific as, is the weather affecting COVID-19? You cannot answer that question clearly and with finality, because there's so much unknown in between the countries that you are looking at and within the countries that are doing the testing.
And the same problems could apply to much bigger questions. They're actually really worried that, interestingly enough, it seems like they're really worried, this is very early in the pandemic, that the governments will relax their precautions too much as a result of certain conclusions that they draw.
Right. So basically, they're saying studies that are interested in the effect of containment policies may have to consider that these policies substantially affect testing because they change the awareness of the disease in the population, political demands for more testing, or the risk of contracting other respiratory diseases. Other studies may also produce estimates that are very specific to the current circumstances in the development of the pandemic and are, therefore, not suitable to use for forecasts of what could happen in the coming months. In short, Like, be very careful. Don't look at the numbers and assume that they are inherently golden and that they will give you an accurate readout. And until we take a step back and we really start to ask the question of how good are our starting assumptions and how fine grain is our analysis of the sample from which we're pulling our average positivity rates and our negativity rates. Like, we would strongly caution anyone from making large claims about any of this, because you cannot see through the effect that something like lockdown has in order to be able to tell what's happening on the other side of it if you had never done it. Which is not to say that you shouldn't do lockdown. It is to say that the people walking around and crowing about the efficacy of lockdowns might not be estimating what's happening underneath them correctly. And on the other hand, the people that are saying that lockdowns are useless and we shouldn't be doing them are also unable to see through the things that people are doing that are confounding the data.
Which is a profoundly disturbing realization, because we started to get into this before class or before the lecture a little bit, but there's this very real human tendency to, when we find a number hung on something, to see it imbued with truth. And the more precise that number is, the more truth that we inherently, intuitively assume is offered. So if I tell you that, you know, there's maybe, let's say there's two out of three chance like that I'm not going to make it to class next week. And then I come back and I'm like, no, actually, it's more like a 68% chance I'm not going to come. It sounds so much more certain when I start adding decimal places to it. And the more decimal places I add to it, the more you'll think that I'm actually expressing a certainty about that. When in reality, it could just be the averaging came out that way, and it's a completely irrational number that goes on forever. It has nothing to do with my certainty. But just hanging numbers, and the more numbers you can hang on something, it tends to bypass our intuition and lead us to believe that there is added certainty in that estimate. When in reality, there's no problem with the way that these numbers have been cranked in any of these examples we've looked at today. All the numbers are fine. The question is, what do the numbers actually tell us about what's happening in the world?